Hello students, the name of this lecture is Antimicrobials used to treat gynecological infections. My name is Jeff. Let's get started. These next 5 slides are for your board prep material. Here's a bugs and drugs cheat sheet. When you see this, consider using that. Here's a different slide depicting different classes of antibiotics, and this is a broad overview. There's 12 classes of antibiotics listed here and a timeline of their discovery. Different examples of each. Distinct modes of actions. Here's a list of key antibiotics classified by their mechanism of action. Metronidazole targets DNA synthesis in the bacteria. DNA gyrases or quinolones or fluoroquinolones. Rifampicin targets RNA polymerase, so on and so forth. Here's a different slide showing different mechanisms of action of key antibiotics, providing you a different view of how antibiotics work. This is a nice chart that classifies drugs by their mechanism of action and gets into a great level of detail with the different types of antibiotics that work through different mechanisms of action. Finally, here's some supplementary learning resources for your board prep material, to include some YouTube videos, other videos that I've put together for you. This is all supplementary material. None of the previous 5 slides will be covered on the exam. Here are your learning objectives. In order to treat gynecological infections, compare and contrast the choice of specific antimicrobials as needed, to include those listed here. In order to diagnose these conditions, describe the process of determining a differential diagnosis for these types of gynecological infections.
Bacterial vaginosis is a disease of the vagina caused by excessive growth of bacteria. Common symptoms include increased vaginal discharge that often smells like fish. Common organisms include Gardnerella vaginalis and other Gardnerella species. Treatments, either PO or vaginal cream formulations available, include metronidazole or clindamycin. I'd now like to provide some clinical pearls for bacterial vaginosis. An asymptomatic partner does not need any treatment. You may want to substitute tinidazole in non-pregnant patients. A single dose of metronidazole is no longer recommended. Oral or vaginal regimens are acceptable in pregnant patients. There's insufficient evidence to support treatment in asymptomatic patients, including pregnant patients. I'd now like to talk about vulvovaginal candidiasis, which includes excessive growth of yeast in the vagina that results in irritation. Typical symptoms, which may be severe, include vaginal itching, burning during urination, a thick white vaginal discharge, typically does not smell bad, pain during sex, and redness around the vagina. Common organisms include Candida albicans. There's intravaginal therapy for uncomplicated cases. These preparations are available over the counter to include chlorotrimazole, miconazole, and teoconazole. There's intervaginal therapy for uncomplicated vaginitis, but prescription medications include nystatin, terconazole, and butaconazole. And there's also oral therapy for candidiasis to include fluconazole. I'd now like to provide some clinical pearls regarding candidiasis. Only a topical imidazole is recommended during pregnancy, to include chlorotrimazole and miconazole. Severe cases should be treated with the topical azole or 2 sequential oral doses of fluconazole. Topical azole drugs are more effective than nystatin, and there's no treatment of their sexual partner needed. Trichomoniasis is a sexually transmitted infection which is most often spread through vaginal, oral, or anal sex. It can also spread through genital touching. People who are infected may spread the disease even when the symptoms are not present. When symptoms do occur, they typically begin 5 to 28 days after exposure. Symptoms include itching in the genital area, a bad smelling thin vaginal discharge, burning with urination, and pain with sex. Having trichomoniasis increases the risk of getting HIV/AIDS. It also may cause complications during pregnancy. The common organism is Trichomoniasis vaginalis. Initial treatment is metronidazole and tinidazole. Persistent, recurrent, or HIV-positive patients should be prescribed metronidazole. Some clinical pearls regarding trichomoniasis include: there's no effective alternatives to nitroimidazole therapy. Therefore, IgE-mediated allergic patients need to be desensitized to the drug. Sexual partners should be treated. Sexually active women should be retested 3 months after completing treatment because of high reinfection rates. Preferred treatment in pregnant patients is metronidazole. Mothers should avoid breastfeeding and alcohol abuse 24 hours after the last dose of metronidazole or 72 hours after the last dose of tinidazole. Persistent trichomoniasis should be treated with metronidazole or tinidazole for 7 days. Evaluate for reinfection for untreated partners. The preferred regimen in children is metronidazole, and then evaluate for sexual abuse. Urethritis is inflammation of the urethra. The most common symptoms include painful or difficult urination and urethral discharge. It's a commonly treatable condition, usually caused by infection with bacteria, often sexually transmitted, but not in every instance. It can be idiopathic, for example. Some incidents of urethritis can appear asymptomatic as well. Cervicitis in women has many features in common with urethritis in men, and many cases are caused by sexually transmitted infections. Non-infectious cases of cervicitis can include IUDs, contraceptive diaphragms, and allergic reactions to spermicides or latex condoms. Cervicitis affects half of all women during their adult life. Co-infection is common with gonorrhea or chlamydia. Clinicians should treat for both. Common organisms include Neisseria gonorrhea, C. trachomatis, U. urolithicum, M. genitalium, Trichomoniasis species, and herpes simplex virus. Drugs used in this instance include ceftriaxone and azithromycin. If your patients have an azithromycin allergy, replace with doxycycline. If there's a severe penicillin or cephalosporin allergy, azithromycin plus gentamicin intramuscular or gemcitabine. Some clinical pearls include test known contacts within the past 60 days. Or most recent partner if contact is greater than 60 days prior. Patients should abstain from intercourse until 7 days after therapy is initiated and symptom resolution and partners have been treated. Fluoroquinolones are no longer recommended for treatment for gonococcal urethritis because of rising levels of resistance among Neisseria gonorrhea isolate. Retesting at 3 months recommended because of high recurrence rates. Consider testing patients for other STD, STIs such as HIV and syphilis. Consider treatment with metronidazole for Trichomoniasis species and or Bacterial Vaginosis infection, especially in resistant cases. Test of cure recommended 3 to 4 weeks later for pregnant women and 14 days for individuals receiving an alternative regimen. Pelvic Inflammatory Disease is also known as PID or Pelvic Inflammatory Disorder. Pelvic Inflammatory Disease is an infection of the upper part of the female reproductive system, specifically the uterus, fallopian tubes, and ovaries, and inside of the pelvis. Common organisms include Neisseria gonorrhea, C. trachomatis, S. agolactiae, G. vaginalis, enteric, gram-negative rods, and anaerobes. In an outpatient setting, clinicians can prescribe ceftriaxone and doxycycline. If the case is complicated, consider adding metronidazole. For example, if there's a tubo-ovarian abscess or recent gynecological instrumentation has been performed. Inpatients, doxycycline plus cefoxitin or cefotetan. Clindamycin and gentamicin are recommended during pregnancy. Some clinical pearls to consider for pelvic inflammatory disease. If there's a suspected tubo-ovarian abscess, you should consider admission to the hospital. TOA is an inflammatory mass found in the fallopian tube, ovary, and adjacent pelvic organs. TOAs occur in about 15% of women with pelvic inflammatory disease, with 100,000 admissions per year in the United States. You should also consider admission if your patient is pregnant or if the patient presents with nausea, vomiting, high fever, or failure of outpatient therapy. Any patient if compliance or follow-up is questionable. Fluoroquinolones are no longer recommended because of rising levels of resistance in Neisseria gonorrhea isolates. Maybe consider for outpatient regimen if true cephalosporin allergy. Clinicians could consider testing the patient for syphilis or HIV. Sexual partners within 60 days should be treated. If no intercourse within 60 days, treat the last partner. Both the patient and the partner should abstain from intercourse until adequately treated. For example, until therapy is completed and symptoms are resolved. Endometritis is inflammation of the inner lining of the uterus, also called the endometrium. Symptoms can include fever, lower abdominal pain, and abnormal vaginal bleeding or discharge. Common organisms. Endometritis is often polymicrobial, including anaerobes, C. trachomatis, and M. hominis. Non-obstetric endometritis. Clinicians can consider prescribing ceftriaxone and doxycycline. If the case is complicated, again, if there's a tubo-ovarian abscess or recent gynecologic instrumentation procedure, consider adding metronidazole. Postpartum or recent gynecologic procedure, clinicians could prescribe gentamicin plus clindamycin or, alternatively, ampicillin and sulfbactam, also known as Unison. Some clinical pearls regarding endometritis. When patients have had a C-section, they're more likely to have an anaerobic infection. 1 day to 1 week postpartum, in other words, early, infection usually occurs after C-section. Late postpartum, 1 to 6 weeks after giving birth, infection usually occurs after vaginal delivery. Can present as postpartum hemorrhage. Consider removal if intrauterine device is present. There's no clinical improvement within 48 to 72 hours of antibiotic initiation. Patients presenting for medical treatment after a sexual assault may be concerned about the possibility of acquiring an infectious disease. For many types of STIs, providers should administer appropriate therapy to prevent this transmission. However, some of the STIs have become resistant to commonly used antibiotics. Common organisms include C. trachomatis, Neisseria gonorrhea, Trichomoniasis species, hepatitis B, HIV, HPV, and tetanus. Gonorrhea, chlamydia, Trichomonas can be treated with ceftriaxone and azithromycin plus either metronidazole or tinidazole. If there's a recent alcohol ingestion or emergency contraception has been provided, metronidazole or tinidazole can be taken at home. If the patient is known to be vaccinated and has documented immunity, hepatitis B vaccine is not indicated. If the patient is vaccinated but you're uncertain of the immunity, go ahead and give a single dose of hepatitis B vaccine. If your patient is unvaccinated, you should give an initial dose within a day, preferable, then follow up doses at 1 to 2 months and 6 months. If unvaccinated or uncertain immunity and assailant is known to be HPV positive, hepatitis B immunoglobulin should be administered. Hepatitis B immunoglobulin, not to be confused with vaccines, are immune globulin shots. They're different. These shots contain large amount of hepatitis B antibodies taken from donated human blood. These shots are given when immediate protection against Hep B is needed. Hepatitis B immune globulin provides immediate protection because it contains preformed antibodies to hepatitis B. However, the protection is only short-term and there's no long-lasting memory B cells. Some clinical pearls regarding sexual assault STD, STI prophylaxis. Serologic testing for syphilis and HIV is recommended by the CDC. Consider pregnancy prophylaxis, levonorgestrel or Opristol, or copper IUD up to 5 days post-assault or post-ovulation, whichever is longer. Also, consider tetanus prophylaxis. Syphilis is a sexually transmitted infection caused by the bacterium Treponema pallidum. The signs and symptoms of syphilis vary depending on which of the 4 stages in which it presents: primary, secondary, latent, and tertiary. Again, the common organism is Treponema pallidum. Early latent is acquired in the past year. Benzathine penicillin is the drug of choice. If there's a severe penicillin allergy, doxycycline can be used. In the case of neurosyphilis or ocular syphilis, aqueous crystalline penicillin G, procaine penicillin G, and probenecid can be used. Clinical pearls regarding syphilis. Penicillin G is the treatment of choice. There's limited data on the efficacy of other regimens. Patients should abstain from sexual activity for 7 days following treatment completion. Pregnant and neurosyphilis patients should be desensitized and treated with penicillin. Sexual partners from 90 days preceding diagnosis should receive empiric primary syphilis treatment. All sexual partners should have serologic testing performed. You should counsel patients on potential Yarsch-Herxmeyer reaction, which includes rigors, fever, myalgia, typical within the first 24 hours of treatment. It's recommended for your patients to have a lumbar puncture for ocular complaints, neurologic symptoms, or if they're HIV positive. All patients presenting with syphilis should be tested for HIV. Children greater than 1 month, if not congenital, consider evaluation for sexual abuse.